For that, we have questions for you. This is basically prepared by Prof. Lucy. So you can key in now. Prof, okay, we'll carry on with another question. This is what we call siapa makan cili dia terasa pedasnya. Okay. Very honest. The next one. Very interesting. Right. Prof. Lucy? She will be talking on clinical cause and principles of management of dengue. Okay, there's another one, sorry. All right, so a round of applause to Prof. Lucy.
Good morning. Can you hear me from the back? Yeah? Okay. Good morning, everyone, and thank you for spending your Saturday morning with us. I'm going to talk about the clinical cause, but before that, about the questions that we've just posed to you, about I remember the reason I posed some of the questions was at the height of the dengue outbreak. Some of the senior consultants, when we were sitting down and talking, and then they were all asking, why are there so many cases? Shouldn't the government be doing something about it? Government? Shouldn't the government be doing something about it? So I just asked this question, around the table. How many of you actually do the 10-minute checking for breeding sites? So that was the response. And I was quite surprised, quite a number, and these are very senior consultants in the Ministry of Health and in the hospitals. They said, my house has no mosquitoes. There are no breeding sites. I said, no, that is not the question. The question is, do you check for it? Now, all of us has about 10,080 minutes a week. Everybody has it equally. Nobody has more, nobody has less. All of us in 1 week, if you live for 1 week, you already have 10,080 minutes. All you need is to take that 10 minutes out of that 10,080 minutes to do the checking. All right, the question is not whether you have mosquitoes in your backyard or not. It's whether you have breeding sites. All right. So if you have breeding sites, don't talk about you don't have mosquitoes, because actually most of them are actually up there in the gutters. All right. So now, yeah, I won't be able to give you the whole course. Yeah. So how do I use this? Okay. Yeah. You go to this website, the slides, there are a lot more slides at this website, about 200 plus slides with all the explanations, so you would have a big, more comprehensive picture. Now this is in 2013, I don't know what's the current situation in India, but in 2013 they had a big outbreak, and this came out in the news. All right, dengue hemorrhagic shock. And clinical management, there were a lot of deaths, so clinical mismanagement was blamed for the dengue deaths. And this professor of medicine said that the main cause of the deaths in children was unnecessary fluid therapy, a significant cause of mortality. And overload, when you give fluids, and we give a lot of it, and especially when the platelet counts are low and we are busy trying to top up that platelet count, this poses a risk in itself. And we have to go back to the basics, close monitoring of clinical signs and symptoms of the patient, and not the lab report, which says that the platelet count is low. And for any fever, the platelet counts are going to go low for any infection. So the doctors should focus on the general state of the patient without watching for bleeding signs and the change in breathing and proper management. So, I mean, this is kind of in a nutshell what we should be doing. So I'm going to talk about the natural history of dengue first. Now, it is important to understand that, you know, what we are seeing here, the symptomatic severe dengue and the deaths, we are really seeing the very, very tip of the iceberg. Not even the tip of the iceberg, the very, very tip. Because there are lots of infections, and only 5% of those, only 25% are symptomatic infections. The rest are asymptomatic infections. Now, asymptomatic infections is one of the problems, because these patients are also viremic and they are a source of infection for others. So they could be an index case as well. All right. So that's why it is so hard to control the outbreak. So now these patients, out of the 25 who are symptomatic, only 1 to 5% are going to have severe dengue. The rest of them are going to be at the outpatients. So within those people who are manning in the front line, you are seeing these patients and trying to pick up basically the needle in the haystack, these type of patients who should be admitted. Now, what I also notice is that doctors who are manning the front line, sometimes they do the easy way, just open the gates and let everybody into the wards. Into the EDs, flood the ED, the emergency department. So the emergency departments is seeing everybody, and it's so difficult at that level to see the needle. All right, so one of the reasons we run this course is so that you would be a bit more careful, especially those who are running the front line. Manage these patients well so that they do not become here. So it is a matter of management to prevent from here. And getting them early into the ward, do not do that, because there are so many patients. So at the front line, you can do it very well. And so from these patients, then if you send in everybody, nobody can look for the needle then. So that's where the deaths will come. Right? So this is, apart from the platelet count, do remember that the disease it's a systemic disease, because when there is a viremia, the virus goes everywhere, and it causes severe headache, myalgia, gastrointestinal symptoms. It even gets into the bone marrow. And it takes over the function, the engine of the cells in the bone marrow to manufacture the virus. So it is a very systemic disease. So it is a dynamic disease, and it is not just a platelet count disease. So if there's one thing that you learn today from this course, is remember that dengue is not a platelet count disease. Now, after the incubation period, so the patient gets bitten by a mosquito here, and after about 3 to 5 days, depending on the amount of virus that was inoculated, the patient then suddenly develops a fever. All right? Fever is very abrupt, and together with the fever, the patient is viremic. It's got the headache, nausea, myalgia, body aches, and sometimes a rash. And this febrile phase lasts about maybe 3 to 5 days. And after that, that is when you are going to see whether there is going to be a problem or not. Now, if they do have a problem, they go into what we call the critical phase, and this commences at a time of defervescence. And what happens at this time, what makes it so critical, is that the patient develops significant plasma leakage. Defervescence is defined when the body temperature goes down to not afebrile, but less than 38, and it stays below that. Now, the critical period, that period of plasma leakage lasts 48 hours, and if patients survive this period, they go into a recovery phase. And that's when the plasma leakage stops and fluid that has leaked out starts to come back into the system. So you need to have this big picture in front, in your mind, so that when you see the patient, you try to navigate your patients through, because through every phase, the problems are very, very different. So again, putting it into a schematic, the top line is the days of illness, and these are the phases. So during the febrile phase, the temperature is very high, and it corresponds with the viremia. Okay? So towards the third, fourth day, the viral load comes down, and that's because your antibodies are being produced, either IgM in a primary infection or IgG in a secondary infection. So this time, the fever comes down, and the patient goes into what we call a defervescent phase. And sometimes when they go into, that's the start of the critical phase, and then when they go into severe, in the midst of the critical phase, the temperature can be subnormal. Now, at the end of the critical phase, there is another blip of temperature that goes up again, and this is, gives rise to what we call a saddleback, okay, as a double hump, a biphasic temperature. Now, looking at the white cell count, earlier on, Dr. Venu has already mentioned that in the beginning of the illness, the counts are actually normal. The total white count is normal, but towards the end of the febrile phase, second, third day, you start to see the white cell count coming down. Right? That's because, you know, the bone marrow, the cells in the bone marrow, they have stopped. Okay, that's the only way they can survive the viral attack is to shut down the machine. So no more white cells come out from the bone marrow. So whatever cells that are already out, they will just slowly live out their lifespan. So the white cell count starts to come down. So does the platelet. The platelets also stop production, so the platelet count started sliding down. But towards the end of the febrile phase, coinciding with the the appearance of antibodies, you see a very steep drop in the platelet count. All right, so this is, again, tells you, so if you're navigating your patients, so you need to pay attention to all these. You do not have this, but then you have the temperature and you have this. That tells you that your patients are going into the critical phase, and it stays low throughout the critical phase. So now we know that if you can see the correlation, you know that the critical phase, the phenomenon of increased capillary permeability is not driven by the virus, but is immune driven. Okay, because that's when the antibodies start to appear. Now, if the plasma leakage goes up, increases, then the hematocrit increases. Okay, it peaks at a time when the platelet counts go down. All right, and then it comes down with as the capillary permeability resolves. Now, if you are starting your patients on an IV drip, which I see nowadays, people, you know, we have this kiasu culture in our patients as well as doctors. They start an IV drip in the febrile phase, then you will not see this. Okay, so you miss out a lot of the features that would tell you that will guide you how to navigate your patients through. Now, what are the potential issues then? Now, the potential issues in the febrile phase, because they have so much fever, they are viremic, they have nausea, they have severe headache, they actually do not want to drink. If you are not sick, but you just, like you are in a fasting state, it is okay. But if you have fever, and then if you have vomiting, and then if you have, you live in this climate, high fever, hot temperature, if you don't drink for a day, you become dehydrated. If you don't drink for 2 days, you are near collapse state, just without the fluid, adequate fluid. So dehydration is a big issue during the febrile phase. And the answer to the dehydration is not an IV drip. Like I said, if you start an IV drip, you will miss this picture, and then you wouldn't know that this is happening. And then by the time it hits you, you know what will happen? The patient is already overloaded with huge pleural effusion, all right, and still in shock. So be very careful. We do have, I don't know, I didn't put up we have a tool on the YouTube talking about how to manage oral hydration during the febrile phase, and I think Dr. Ho would be talking about this. Managing the fluid intake is very, very important. Okay, starting an IV drip is not the answer. Now, then towards the end, when the fever coming down, the platelets are coming down, you see another phenomenon, the capillary permeability. All right. Now, this increased capillary permeability, studies have shown that it actually starts during the febrile phase itself. All right, so that's why it is dangerous to give an IV fluid here, because instead of making it a 48-hour capillary permeability, you have extended it to maybe 96 hours. Now, that will be a challenge. So the urine output at that time will be poor, and if the patient has significant plasma leakage, they will go into hypovolemic shock. And if this shock is not managed quickly, then the patient starts bleeding, and then it becomes extremely difficult and challenging. Now, if they survive this phase, the plasma leakage resolves, fluid gets reabsorbed into the system, and if you are not aware and you are still giving IV fluid, you create another problem for the patient, which is fluid overload, and a lot of our patients actually die at this phase. Now, organ impairment is usually in relation to the hypovolemic shock, but sometimes in some situations it goes beyond that, and Dr. Tan Lien Huat will talk about it. There's a phenomenon called a macrophage activation syndrome, which occurs around here when the high fever, the second blip of temperature, and if organ impairment actually gets worse because of macrophage activation. So you can see that the immune system is actually a very big part, and that will it will determine the clinical manifestation. Now, there is, I'm sure by now you would appreciate that the spectrum of the clinical manifestation is very wide. You can have very mild dengue to severe dengue, and it is very difficult to predict how the disease will evolve. Now, it is important that whatever it is, whether mild, severe, it is a self-limiting in vast majority of patients. 99.9 is self-limiting, meaning that we are not doing the curing for the patient. There is no antibiotic, there's no antiviral. The immune system will cure. The patient's body will heal itself. And what we are doing as doctors is to keep the patient alive without putting him into hypoxia, acidosis, and organ impairment, and let the body heal itself. Severe disease in a small proportion of patients is, most of these severity is characterized by plasma leakage. With or without hemorrhage, there are some patients who present with severe hemorrhage with very minimal plasma leakage, but those are very small. Now, the old classification, some of you, I don't know, maybe still hanging on to the old classification, 1997, last revised in 1997, where the patients are classified into dengue fever, dengue hemorrhagic fever, dengue shock. Now, this system has been replaced in 2009 with a revised classification, and this classification is supported by clinical studies in Southeast Asia and in Latin America, and is based on a set of clinical and lab parameters. And what the study shows is that there is a clear-cut difference between patients who had non-severe dengue versus the severe dengue. Okay, it's very clear-cut. And the classification, using the new revised classification in 2009, helps the clinician in making decisions about the type of how intensity the treatment would be and your intensity of the observations. So basically, it is dengue and severe dengue. So that the study came up with very clear guidelines of what constitutes dengue and what constitutes severe dengue. Now in this study, on which the 2009 classification is based, severe dengue is defined as severe plasma leak, meaning that you might have mild plasma leakage, but you don't need an IV drip. Body can compensate, the patient can survive without an IV drip. Yeah. So it is the severe plasma leakage that will make it severe dengue, or mild bleeding, with a little bit of gum bleeding, epistaxis, that is not going to make it a severe dengue. It has to be severe hemorrhage. And similarly, severe organ impairment. Now, the starting point of using the classification is making the diagnosis of probable dengue or a lab-confirmed dengue. Okay. Now, based on this 2009 classification, the probable dengue is these criteria: people who live or travel to the dengue endemic area and has fever plus 2 of the following: nausea, vomiting, rash, aches and pains, the aches and the body aches and the bone pains and the muscle myalgia, positive tourniquet test, a leukopenia, and any of the warning signs. So fever plus any. They may not be simultaneously present. Or if it is a lab confirmed, nowadays we have NS1 that's lab confirmed. So if your starting point has to be that. Okay? And then from there, then you then do what we call this classification, look for warning signs. Okay? Warning signs. Now the warning signs are those that come on after 72 hours. That means at the end of the febrile phase, that's when you start to pay attention to these. Abdominal pain, very severe abdominal pain, tenderness, persistent vomiting. So in the beginning, the first 2-3 days, because of the viremia, they may have some vomiting, but we would not consider that as a warning sign. That is very, very important. Otherwise, we will have another deluge of patients coming in at day 1, with warning signs. Now, day 1, day 2, day 3, we are not talking about warning signs. Those times, they are viremic, and we have to manage their oral hydration. Okay. So the ones that we call the warning sign are the ones that come in after 72 hours of the fever. The mucosal bleed, especially those young women who are still menstruating, you have to be very careful with them. They could bleed excessively. Lethargy, restlessness. So in the viremic phase, they are also a little bit lethargic. Yeah. So, but this one is excessive. More when the fever comes down. Now, when the fever comes down, the patient in all other viral illnesses is a sign of recovery, right? You say, oh yeah, fever goes down, good. It's a good sign. But in these patients, when the fever comes down and they are still lousy, now you've got to be a bit careful. Don't just say that, oh yeah, you just go and sleep, you'll be okay. You never wake up from the sleep, right? So the lethargy at a time when the fever is already down, you have to be very careful. Then the liver enlargement, clinical fluid accumulation, and increase in hematocrit with a rapid decrease in platelet count. These are warning signs. So we use these to guide us in our management. So bear in mind that warning signs, those that we are going to admit them, for which they going to be admitted, are those that occur after 72 hours of the symptom onset. All right? Now, what is the criteria again for severe dengue? Now, severe plasma leak. We said that a lot of patients will have mild leakage, all right, especially the adult patients. But when they get into shock, yes, it is considered as severe plasma leak. If you start an IV drip and they never get into shock, but they eventually develop respiratory distress because they're so big, their pleural effusion, then it must be that they had severe plasma leak. Severe bleeding, mild bleeding is to be expected in the most cases of dengue, even without those without the warning signs, but it's the severe bleeding. And this bleeding is enough to cause hemodynamic instability. And another definition for the severe bleeding is that when you have given your IV fluids, your colloids, and they are still, not stable, so they may require blood transfusion before they are stabilized, then they are classified as severe dengue. So it is a very clinical diagnosis. Now then, the third category of patients are those with severe organ impairment, those with enzymes that are high. Now, liver enzymes are raised in a lot of dengue patients, but it's when it is high that we call them severe dengue, and sometimes CNS impairment, cardiac impairment. Now, a patient may have this without this and this. Particularly the children, they are more prone to plasma leakage, so they have severe plasma leakage, and even though their platelet counts may be 10,000 or even 0, they may not have bleeding at all. Unless you poke them. If you poke them and they bleed, of course, that they will bleed. They will bleed. All these patients are going to bleed. It's whether you traumatize them. So you've got to be very careful, right? So if you're careful, they don't have severe bleeding. Right? Now, some adult patients with peptic ulcer diseases, they can develop severe bleeding. And some patients, they've been given enough, one dose of Voltaren, 1 dose of ibuprofen, 1 dose of Ponstan is enough. 3 days later, they will be bleeding, gastrointestinal, severe bleeding. So this is what we see now. Those who have received IM injection, 3 days later, there is a hematoma over the site. So they don't have severe plasma leakage, but they have this. It's iatrogenic. If we don't use so much medicines, then they would not have this, they would not have this. Now, some patients have only this, only liver enzymes. They do not have this, they do not have that. All right, this is, Dr. Tan will be talking about it, the macrophage activation. So when we label our patients as severe dengue, be very clear which category we are talking about. Because the moment you put in a label severe dengue, people will immediately jump in and say, oh yeah, they need fluid, 10 mils per kg. And that's how our patients are dying. This person gives 10 mils, the next doctor comes and gives another 10 mils, another doctor comes and gives another 10 mils. By the end of the day, they are fluid overloaded. All right, so be very clear which category of severe dengue we are talking about. And if it is organ impairment, like we had a particular patient, she was 19 years old, and all she had was that enzymes were 2,000. Yes, the hematocrit went up from 43 to 50, but she walked in. She was warm, pink, well perfused, and talking to people. And because her enzymes were 2,000, she was labeled severe dengue, pushed into red zone, the 10 mils per kg went in. And she was a big size. Although she was 19 years old, she was actually about 90 kilograms. So you imagine how much fluid she was given, 10 mils per kg. 2 pints just went in, like that, in 1 hour. Suddenly, then of course she will die from, if you are so big, your respiratory reserves are reduced, and then the doctors come in, each doctor gives 10 mils per kg, 5 mils per kg, and everything just adds up. All right? So be very, very specific about the way we go through the evaluation carefully, and when we put the label there, be very specific because a lot of the doctors who come after you may not be going through your notes. They will just look at your label, severe dengue, okay, 10 mils per kg, 10 mils, 7 mils, 5 mils. All these are all adding up, right? Now, if it is severe bleeding, then the management is again different. So each of these 3 categories of severe dengue have different strategies in the management. Now, of course, patients can have combinations, this one and this one, or this one and this one. So you need to be very clear which one are you talking about and how you're going to manage it. Is that clear? So don't just everybody blanket everybody with severe dengue and then everybody gets the same management and patients die. Yeah. Now I'm going to spend the rest of my slides talking about IV fluids. Okay, and these are the 6 questions that we would answer. Who should get it? When to start? When to stop? How much should the IV be? What is the rate that you have to give it at? And what type of fluids? Now, who should get an IV fluid? It starts with the history. All right, like basic medicine, you start with the history, not with the NS1 positive. The problem is now we have so many of these diagnostic studies, clouding our mind. Oh, NS1 positive, IV fluid. Yeah. So important is date. This date will tell you whether you are more than 72 hours now or less than 72 hours. All right. Symptoms and severity. All that body aches, if you don't have NS1, you still go through this. And then, very important, I call them the 3 golden questions. And the 3 golden questions are, how much fluid can the patient take? What is the quantity? It's not just a yes, no. Fluid intake, tick. Urine output, tick. What activities, tick. It's not a tick, tick, tick. Okay, you have to go down to the ground and find out how much they can drink, what fluid they are drinking. Now, a lot of our patients have poor appetite. They are not eating. You ask them to eat, cannot swallow. It's like wood, they're eating sawdust. They tell me, it's all dry and caked and nothing will go down. All right, so all they do is therefore drink. Because the doctors scatter, minum. I say, what do you minum? Oh, air masak, air swam. 3 days you air masak, air swam. What do you think? They will become weak and lethargic. They're not in shock, but they're weak and lethargic because they have no more electrolytes. All the electrolytes are down. Their sodium is down, potassium is down, calcium, phosphates, they're all down. Down in the boots there because they've been drinking air masak. All right, so quantity, quality of fluid. Now, urine output. Okay. Now, the best indicator of whether they are taking enough fluid intake is that they must pass enough urine. Okay? How much? Not just tick, pass urine. How much are they passing? When was the last time they passed? So usually we say that 4 times, at least minimum 4 times a day. All right. So every 6 hours you need to go to the toilet. 4 to 6 hours. Now be very careful of those who are diabetic. And we have a lot of walking diabetics never diagnosed. Right? So they don't need to drink, they will still pee. So when you're taking the history, you got to balance these 2. Oh, if you don't drink, and how come you're peeing? Something doesn't equate, right? You need to check the blood sugar. So these are things that general medicine. Don't think that this is all about dengue. It is general medicine. About fluid intake. If you're not drinking, you shouldn't be passing urine. That is what your kidneys do for you. If you have chronic renal disease, you have diabetes mellitus, you have diabetes insipidus, yeah, you won't need to drink, you will still be peeing, but you'll be peeing to die, to your death. Right? So these 2 must add up, must balance out. Now, what activities can the patient do during the phase? Now, if you make a diagnosis of viral URTI, and then you said, what are you doing? Viral URTI, sleeping at home for the last 3 days. Is it viral URTI? Does viral URTI, a sore throat, tonsillitis, make you sleep 3 days in not wanting to watch television, not wanting to eat? Does it do that to you? You have to ask that kind of questions. Right? So a lot of us who work in the government side, at least in our university hospital, we have no money. So we can't do NS1. So we have to go through these 3 questions all the time to make sure that we don't miss our patients. All right? Now the other questions are, what are the fluid losses? A lot of them have diarrhea. So if they are not drinking, they have diarrhea, they have nausea, you don't need to be a rocket science. This is not rocket science. You know for sure they are dry. Even the parents who never go to university will know that the child is not getting enough fluid. And then, of course, we have talked about the warning signs. So going through this basic history is very important, and it will tell you which type of patients need an IV drip. Now, in your clinical evaluation, it is very important. Now, I see doctors, when I go to the clinics, and this is a fever clinic, so most of the patients are going to be dengue patients. And I see doctors taking their stethoscope, putting on the chest. What are you going to do? What are you going to pick up? You're just doing an acting only. I say this is Sandiwara. What you really need to do is to hold the patient's hand. And by just holding the patient's hand, you can pick up the patient's shock very, very quickly. 30 seconds, there's no machine that can tell you that. Not even the pulse oximeter that costs 10,000 ringgit will tell you this. Just by holding the patient's hands, you can pick up 5 things about the patient. The color of the extremities, the capillary refill time, the temperature of the extremities, the pulse volume, and the pulse rate. So we call this the CCTVR. And it's so magical because when I taught this in places where there are no machines, they are so excited because they can pick up shock. And you don't need to be a doctor. In fact, the first person who picked up the shock was a medical assistant in a very far-flung island in the Pacific. They don't have anything. They don't even have oxygen or X-ray machines, okay? So don't talk about anything else, okay? So we just teach them simple things like CCTVR, hold the patient's hand, you just do all these, 30 seconds you can recognize shock. Now, you have to go through this 9 parameters that give you an evaluation of the patient's hemodynamic state. And they're all clinical parameters. And we do them all the time. So although there are 9, you can actually group them. Okay? The capillary refill time, extremities, temperature, color, pulse volume gives you the idea of the peripheral perfusion. These 3, the heart rate, pulse pressure, and the blood pressure gives you an idea of cardiac output. We are talking about shock, hypovolemia. So we are talking about volume all the time, volume in the circulation. So cardiac output is very important, and just feeling the patient's pulse tells you the cardiac output, the stroke volume. Now the other 3, the third category are perfusion. If you have enough cardiac output coming out, there should be enough perfusion to your organs. So these are end organ perfusions. The conscious level tells you the end organ perfusion. The urine output that we stress so much on tells you how much about renal perfusion. And the 4th thing of the respiratory rate tells you what is the respiratory compensation to the tissue hypoxia when there is shock. All right? Now this is before IV fluids go in. Once the IV fluid goes in, then your respiratory rate may not be a reflection of tissue hypoxia, but a reflection of the amount of pleural effusion. So by holding the patient's hands, you already picked up about 4 out of 9. So fast, very quickly. Now this so in a stable circulation, a patient's capillary refill time should be less than 2 seconds, warm and pink in his extremities, good pulse volume. Now when we do this, you have to be very careful. And even a room that is as cold as this, you don't expect the patient to be warm. Okay, if the patient is warm, something is wrong. It's septic shock, all right? So he has to be cold. But his capillary refill time, I don't know, go and check yours. Is it good? Now, it is going to be a little bit tricky, right? But what will not change so much is the pulse volume. Right? Now, when a patient is having a high fever, the temperature is rising from 37 to 39. This perfusion has to be abnormal. All right? Otherwise, the temperature cannot go up to 39 to 40. All right? It has to shut down. So when it shuts down, these will be a problem. But the pulse volume is still preserved because the pulse volume is a direct reflection of your cardiac output. I hope you know that. I hope you know physiology. You need to know a lot about general medicine to manage dengue. Okay? You just go for a 1 hour or 1 day dengue course and then use that knowledge alone is not enough. You need to use all those 5 years of training. Perfusion, the brain perfusion, the conscious level, clear and lucid, can talk to you, and the urine output being good. and the normal respiratory rate. Now, when the patient is in compensated shock, now these are time continuum, meaning that once they start leaking, and they continue leaking and leak and leak, this is from a stable circulation to compensated shock is a matter of time. Now, how much is this time? Depends on the degree of leakage and the age group. Now, I will tell you that in an adult, they can last about 24 hours with plasma leakage. Because they can, number one, their leakage is not so much. Number two is their leakage, they can compensate fairly well. And they will therefore only get very sick towards after the 24 hours. But in children, it is about 4 hours. It is very fast. If tonight, if you send a patient home tonight, he starts vomiting, and the mother says, oh, 8 o'clock tomorrow morning, I have an appointment. Sorry, by that time, by 8 o'clock next morning, the child is clapped out, okay? So this is a time continuum and is very age dependent. So in the compensated shock, the capillary refill time, because the skin is a non-vital organ, it will be the first to be compromised. So the capillary refill time is prolonged, extremities are cool, and the pulse is weak and thready. Right? And the cardiac output is reduced, therefore there is a tachycardia. The pulse pressure narrows, and the pulse pressure narrows not because the systolic is low, but it's a rising diastolic, which tells you that there is vasoconstriction. So they are all actually interrelated. They are not like 9 separate. They are all related to each other. All right? So the rising diastolic is a manifestation of vasoconstriction. Vasoconstriction gives rise to poor perfusion, and that maintains your cardiac output, maintains the blood pressure, and that's why we call it compensated. You compensate to all these to make the blood pressure normal. All right? Now, because the blood pressure is normal, the perfusion is still okay, so the patient is still talking to you. They're still walking. So can you imagine? They do not have a shock on their forehead. They're walking to you, looking at you, talking to you, and they are already in shock. All right? So perfusion is normal, but if you ask them about the urine output, yeah, it's there. The tissue acidosis, they're tachypnea. They're breathing fast, without effort, not like the asthmatic patients. All right, they're just quietly there, breathing fast. Okay, so you can see that in compensated shock state, everything has changed except the conscious level and the blood pressure. Now, if you are looking at blood pressure, oh, patient looks normal. Yeah, of course they look normal. They can talk now. He looks normal. You know, an hour ago he was so normal. Blood pressure is still normal. How come he collapsed now? Suddenly collapsed. Yeah, suddenly, because all you did was look. You stand at the end of the bed and you look, right? So you have to touch your patients. You have to hold their hands and do the CCTBR and go through the whole gamut of this. It doesn't take long time. Let me tell you, although it looks like long, it's actually, once you get it into your head, it's very fast. How to get it into your head? Keep practicing. Keep using it, all right? Now, the key point when they go into hypotension is that change in mental state. So once the blood pressure drops, they cannot maintain a cerebral perfusion anymore. So they start to become very restless, extremely lethargic, or sometimes they become very, very violent. All right, you say, oh, patient violent. Actually, he's in shock. Okay. Now, in infants, children, how? Macam mana? Okay, so those of us who are pediatricians, we know. We always ask the mother, right? Your anak look at you or not? Or recognize you or not? That's very easy. Actually, the mothers are very, very smart. You ask them, they will tell you, because they are taking care of the patients all the time. And they love their child, so they know what is going on. They will say that, no, my child don't know, something is wrong. They don't make eye contact anymore. Doesn't look as if he recognizes me anymore. You know how children will follow their mother. You know, the mother goes here, the eyes will follow. They don't do that anymore. The parents notice it. But they don't know what's going on. Right? So when the parents tell you that something is wrong with my child, you better listen to parents. All right? They know something is wrong. We don't know because we don't take care of the child. So you listen to the parents. If you are wise, you just listen to your the mothers. Let the mother tell you what to do. Okay, but be very careful. The young children, the older children and the young adults, they have clear mental state. I will show you a picture later on. Very clear. They are walking around talking to you. All right? Which is why they die very fast, because they hold on until the very last. Right? So this is imminent cardiorespiratory collapse. If they go into that restless state, that's why it is hard to pick up a dengue shock. All right? So reduced perfusion, we talked about that. Now, when I taught this a couple of years ago, there are a couple of doctors who said that what they did was they print out this slide, this picture, this box, make it into half of an A4, mount it, and then fold it, put it into their pocket, and every time they see a patient, they refer. And I think you should do that until you internalize this whole process of hemodynamic assessment. You need to do it. You can't be saying that, take shortcut, I do this, I don't do that. I think out of 9, I just do 2. Cap refill time. Or, cold. Cold, and if the patient is cold, you get an IV drip. All of you will be getting an IV drip by now. All right? So you got to be really, go through it systematically, put yourself through that training, and put it into your heads until you hardwire. I always say that you're wired up, your brain is wired up to do this automatically, even in your sleep. Okay, then who should get an IV drip? So now it should be easy, right? We have gone through the evaluation. So those patients who do not drink enough to pee enough, we should get an IV drip. Now, if they are still in the febrile phase, do be very careful. That IV drip cannot be going on for 24 hours or 48 hours or 72 hours, because by that time they will be fluid overloaded, right? Only short while, just to tide you over. But there are other ways, of techniques of getting a patient to drink. And don't have time to talk, you can go to the YouTube and look at it. Now, those with warning signs during the critical phase, definitely, and those with shock. Now, it is very important. This is a study that came out from the Singapore Tan Tock Seng Hospital, where they did a retrospective review of 1,500 medical records, adult patients with dengue, but who do not have DHF, no plasma leakage or severe dengue at the time of admission. That means they somehow got admitted into the hospital, but they didn't have any warning signs. And 90% of these patients were given IV drip for more than 2 days, only 10% without IV drip. The mean duration of the IV drip was 3 days. And the median volume, look at the volume, is 3 liters, all right? 3.5 liters every day. Do you drink 3.5? I don't know. Maximum 7 liters. Yeah? And of these patients who were not severe at the time of admission, 16% of them developed plasma leakage, 8% developed severe dengue. So this is data that stares at you, okay? So do not, compared to patients who did not receive, the 10% who did not receive an IV drip, those who receive an IV drip have 3.6 times greater risk of developing severe dengue. So your IV drip kills if they don't need it. Okay? So we have talked about when to start an IV drip. So early on, we already said, if the febrile phase, if you think NS1 positive, NS1 antigen positive doesn't equate to therapy with an IV drip. You can admit a patient, but oral fluid. All right? And we have later, I don't know whether with the slides, I don't think we'll be covering oral fluid, but an early IV fluid will give rise to fluid overload. Now, during the critical phase, those patients with a critical phase, they require IV drip for only 24, 48 hours. Very limited. If you're giving IV drip for 3 days, you better change your practice now, even though your patients did not die. All right? Because if you do this practice, 3 days, 4 days IV drip, when you meet with a severe dengue, they'll die. I tell you, sure to die. All right? Because you are treating the 95% non-severe dengue as if they are severe dengue, so they're going to survive anyway. All right? But when you treat the 5% or the 1% as if they are the 95, then they will die. All right? So for patients who present with shock, the IV drip should be even less than 48 hours. Why? Because they already spent 24 hours of shock at home. So they only need another 24 hours of IV drip. Now, during the recovery phase, the IV drip should be stopped so that the extravasated fluids can be reabsorbed. Okay. Now this is a study, ultrasound studies in Thailand. They every day you know what they did in this study? They showed me the bed. This is like a typhoid bed. No, the cholera beds of the old. You know, with a hole in the center. They put the patients there, the chest there, and they go underneath with the ultrasound. And then they found that actually from day 2 onwards, day 2 of fever onwards, the patients already developed plasma leakage. Subclinical. No symptoms, subclinical. All right, so if you start your IV drip early, you just make this subclinical becomes clinical. So it peaks during the critical phase, 1 day after defervescence, and in DF-DHF, mild plasma leakage may not cause hemoconcentration. So the most common pleural effusion ascites, gallbladder wall edema, and the magnitude of that plasma leakage is the main determinant of severity. So we talked about when, so how much now, okay? How much to give? Okay, before we talk about how much, what types? What type of fluid? Now, isotonic fluid. Either normal saline, Ringer's lactate. And if your patients are in shock, perhaps colloids should be the first. Do know what type of fluids that we are using. Okay. The osmolarity in normal saline is 292, which is quite high. Our normal osmolarity is about 285, so it's a little bit higher. Sodium and chloride is actually very high in normal saline, okay, especially the chloride. Now, a slightly lower chloride solution would be Ringer's lactate and Hartmann's, but the problem is that sodium is actually quite low, so it's not a good drip to start off with. What drips should we not use? The half saline, even during the febrile phase. Any glucose-containing drips, because we have a lot of patients who are hyperglycemic and undiagnosed diabetics. But if you think that if there is hypoglycemia, then you would need to use a very limited dose of dextrose and then keep the glucose monitoring. Albumin solutions are useless. So, not useful. Plasma, platelets, all these are going to leak out. Now, this is a study from Nur Azmin, one of our Malaysians who worked in Melbourne when he did the study in Melbourne, and they compared a chloride liberal versus a chloride restrictive IV fluid strategy in just their ICU patients, not dengue. This is Melbourne, so there are no dengues there. And they found that in a chloride liberal solutions like saline, gelatin, 4% albumin, the chlorides are quite high, whereas in the chloride restrictive period, during the intervention, they used only chloride restrictive, Plasma-Lite and Hartmann's. They found that the development of acute kidney injury using the rifle criteria was much higher in the patients during the control period who were on a chloride liberal fluid. So a chloride restrictive fluid resuscitation strategy was associated with a significant reduction in acute kidney injury and the use of renal replacement therapy. Okay? So complications with too much. I'm not saying that you should not use. All right? It is when you use first bolus and then the second one and then the third one, you still continue using the same type of fluid. It becomes too much. Okay? So what do they get? They get a hyperchloremic metabolic acidosis. This metabolic acidosis is a normal anion gap one, and the bicarbonate is low. But if you don't look for this anion gap, you would misinterpret the whole thing as, oh, this is shock is worsening. And the studies have shown that when the chloride is high, acute kidney injury comes in. And so how to avoid these complications? How do you avoid? You have to use sodium chloride. But how do you avoid it? Mix and match. Okay? Mix it around. So after about second, third boluses, after 2 pints or 1 pint, your chloride, monitor your chloride, and if that's going up, change to Hartmann's. Okay? And then you can alternate. Then you can avoid that hyperchloremic acidosis. Now this is a study from Thailand in children with dengue. They found that there are lots of electrolyte disturbances, hyponatremia, even in dengue fever. Hypokalemia and ketonuria. So is this not just about managing dengue? This is about managing the patient who is in a catabolic state. Colloid therapy. Okay, the studies that are coming out from Vietnam show that in the hypotensive shock, it is definitely superior. And if you're giving second, third crystalloid, 2-3 boluses, then colloids would be indicated. And if the hematocrit does not come down, some patients have a hematocrit 48, and still after 2 boluses, it's still 48. You probably want to, this is a very leaky situation, change to a colloid state. But the problem is that it is dose limited. You cannot give like forever a lot. So you need to keep within that 30-50 mils per kg per hour per day. Okay, the effects of colloid therapy is that it stays longer, and because it stays longer, the hematocrit comes down faster, and it restores the cardiac index, the cardiac output faster. And it also gives you another information which I find very, very useful, is that because it reduces the hematocrit faster, you will see that if the patient does not improve with the hematocrit coming down, then you would be switching on to another strategy, thinking about significant occult bleeding. Right? Now, side effects are allergic reactions. It might impair the coagulation and impair renal impairment. So be very careful with the volume. So Frank Starling's law, again, telling you that the main force that is pushing fluid out in the leaky capillary state, the filtration, this is a coefficient filtration, is the hydrostatic pressure. Right? The hydrostatic pressure. So this study I was talking about earlier about plasma microvascular permeability. This is a study in healthy Vietnamese aged 5 to 77 years, looking at the coefficient of filtration. So you can see that in children, the young children, the coefficient of filtration is very high compared to healthy adults. And then towards the end, after 50s, 60s, the filtration increases again. So this could have a impact on when they develop hypovolemic shock in dengue. Now, how much? So we talked about types of fluid, so how much and how fast. So that how much and how fast, the thing that should guide you is that you need to just maintain an adequate perfusion, just enough. Now, what do you mean by a just enough perfusion? It means that the urine output is 0.5 mils per kg per hour. Anything more than that is superfluous. That means you are giving too much. All right? And the volume that is used should be based on the ideal body weight, and you need to titrate it. And titration means that you keep on having to adjust it. All right? You cannot be like flat rate, constant rate. So adjust every 1 to 2 hours. So how much, how fast? In compensated shock, in adults, a little bit more, a little bit less in children, 5 to 10 mils per kg over 1 hour. Because the shock is in hypotensive shock, because there's hypotension, you need to give a larger volume, 10 to 20 mils per kg over a faster period of time. In children, it's slightly larger volume. In compensated shock, 10 to 20. Hypotensive shock, 20 mils. Now, when you're running these volumes of fluid, anything more than 5 mils per kg in an adult, your commitment, your responsibility is to sit next to the patient. Finger on the pulse, so that you are monitoring the pulse volume as the fluid is going in. Otherwise, you will overrun your fluid, and hydrostatic pressure increases, fluid overload occurs, more effusion occurs. Yeah? So after the correction of the shock, cut it down in a stepwise manner. Don't cut it down, down from 10 to maintenance. All right, you've got to cut it down slowly in a stepwise manner. And the rate of plasma leakage will decrease towards the end of the critical phase, and you know this because you have been monitoring the hemodynamics, the urine output, fluid. If they start drinking, it's a good sign. All right, and the hematocrit decreases below the baseline in a stable patient. So this is kind of like the algorithm. The first thing before you start off giving fluids and in a shock state is to get that hematocrit, your baseline, and you might do a cross-matching and LUDs and other investigations such as LFT for these patients. At the very minimum, at least hematocrit. Now, in the compensated shock state, compensated means that systolic pressure is maintained, but there is signs of reduced perfusion. Hypotensive shock means the blood pressure is already low. So the volumes that are used here are smaller than here. So when we make a diagnosis of shock, be very clear, is this compensated or not compensated, or the hypotensive? Because it makes a difference in the way, the volume of fluid that we are going to use and how fast we are going to run. So I see that in our mortality meetings, we have an upgrading of severity. Patients may have good pulse volume, but because the hematocrit has gone up from 43 to 48, immediately the patient gets 10 mils per kg. But his pulse volume is still good. He should not be getting 10 mils per kg. You should be getting 5 mils per kg. Right? So your fluid volume is not a fixed. You customize it to the patient at that time when you see. You are the one who saw the patient, so you should be the best person to make that judgment. All right? Not us at the mortality meeting. Right? When we know that, when we are seeing this, we say that, why are you giving this volume? You are upgrading the severity, and I see this worldwide. It's a worldwide GASU phenomenon, right? Patients are well, they are walking in, but hematocrit is high, 10 mils goes in, like as if this is like nothing. This is what I call, what my consultant used to call, shooting from the hips. Huh? This is like cowboys, take the gun and shoot before you talk. So don't just shoot the fluids in. Think carefully, because the people, 24 hours down the line, the patient will suffer, all right, from the fluid that you give. So your first bolus goes in and you reassess. That's why I said you have to sit next to the patient. For 1 hour, you've got to sit next to the patient and see if the patient improves. If the patient improves, then you cut down in a stepwise manner. So both sides, you cut down in a stepwise manner from 10 to 5 to 7. Now, there is a lot of leeway for this kind of protocol. Why? Because this is 10% science and 90% art. Because that art is your judgment, your clinical judgment. What is your judgment? Your judgment is based on history. How many days have this patient not been drinking? So if he has not been drinking for 5 days or 7 days, surely, you cannot cut down from 10 to 5 just like that. You got to think that, I have got to, he has been dehydrated for several days and I have to give a little bit more. All right? So that is why I call it art. Then, is it going to be for 1 hour or 2 hours? So again, it is art. You have to sit there and think about, you have been drinking up to this morning. Okay, can't be so bad. If you hadn't been drinking for 3 days and now you're coming in, okay, this is where you need to go a little bit longer. 7 meals, maybe for 4 hours or 2 hours or 3 hours. Is that clear? So this is a very much an art. Then, after that, again, you have to reassess the patient and then bring it down. All right? Now, I see doctors don't like to do that. So they give a flat rate, 5 mils per kg. This is bad practice. Right? Now, in hypotensive shock, from 20, you cut it down to 10. And then from 10, you slide down. So it's like a sliding scale. Now, if they don't improve, you need to your reassessment tells you that they're not improving. Check the hematocrit. And if you check the hematocrit and you find that it's increasing, a second bolus goes in. All right? Okay, a second bolus goes in. But if you are receiving a patient from another hospital where the doctors have already been giving fluid and fluid and fluid, sorry, you cannot give the same thing. Right? You got to change to a colloid faster. And you might not have 10 mils to give because the patient cannot even breathe already. All right, so you would have to judge. So use your judgment. So that's why I say by that time it's 99% art. Okay, and then after the volume, reassess, and if the patient improves, again do a stepwise reduction. If not improve, then you check the hematocrit again. So every time patient is not good, you need to check the hematocrit. Not good means clinically you assess his urine output, pulse volume is not good down here. Yeah. And if you find that the hematocrit is decreasing, then you start looking for bleeding. Look for overt bleeding first. NGT, menstruation. Okay. So if you see the blood, doesn't matter what the hematocrit is, you got to get urgent blood transfusion. But if you don't see the blood, Okay? Get another colloid in. This time, make sure it is a colloid, no more crystalloid. A colloid goes on because you want to make sure that whether the colloid can bring down the hematocrit or not. All right? Now, the hematocrit will usually come down after the colloid. And if it comes down, is the patient better? If patient better, hang on. No need to give blood. Now, we cannot be giving blood. Just try the blood and see. There's no such thing as just. All right? Because the blood transfusion will change the hematocrit. And then you have lost a very, very powerful marker of plasma leakage because you have made that hematocrit high, not because the capillary permeability has made it high. And then you would misread the whole situation, mistreat the whole situation. Okay, so now what do you do when there's no sustained response to crystalloid and colloid is to think about bleeding. Now, to determine if the patient, the first thing before you even think about bleeding is to make sure that is the patient stable. Not the hematocrit, not the bleeding that you see. Is the patient stable? Your question is the patient stable based on the 9 parameters that we talked about? All right? And if he's unstable, then you look for one of the following. If you see bleeding, doesn't matter what the hematocrit is, you need to go for bleeding. Especially, I would say, for those postpartum hemorrhage. Even 500 mils. They will say, oh, 500 mils is allowable. But hey, this is dengue. Don't look at the hematocrit. Yeah? A decreased hematocrit after fluid resuscitation, especially after the colloid. Okay, the colloid will bring the hematocrit down. But if the patient, hematocrit has come down, but still unstable, okay. Hypotensive shock, but the hematocrit is normal or low. All right, sure, already sudah bleeding. All right, refractory shock, persistent metabolic. Usually they come as a package, as a whole bundle, not one or two. All right, so you will see them all together. So you have to cross-match. Actually, treatment is actually very simple. I won't talk about it because Dr. Badaria will talk about it, so I won't talk about it. Okay, when to stop. Very, very important. Like, doctors like to start, but very difficult to stop. Okay? Knowing when is critical, when to stop. Because if you don't stop, then the plasma continues to leak and leak. All right? But if you stop, so you do it a stepwise reduction. And then when you get down to 1 ml, half a ml per kg, stopping is nothing. It's a matter of a natural progression. So definitely stop when you see hypertension. And the pulse volume is good. Patient has got breathing difficulty and there are crepitations or there are rhonchi. Suddenly the diagnosis of bronchial asthma comes up, you know that this is pulmonary edema, all right? Or there's 48 hours after defervescence. Okay? How not to miss the point, of stopping the fluid is to quantify the fluid. Accumulate all this fluid, quantify the urine output, and evaluate what happens after your IV fluid. Okay, yeah? Do the CCTVR, do the 9 parameters, and then ask yourself, is the patient breathing? How is he breathing? Is it breathing faster, slower? Is his pain, if he had pain in the beginning, is his pain better or is his pain worse? Okay? How much is he passing out? So I'd like to show you this picture. This is a picture of this girl. This was in a village hospital in Laos. Clearly, from her face, you can see that she has abdominal pain. So the doctors tell me, oh, she's still got warning sign. She's still got warning sign. So zoom out. All right, never jump and shoot at just because the patient has got a abdominal pain. Think, what phase of illness are you talking about? Febrile phase, critical phase, convalescent phase. How long have the duration, was the IV fluid given? What volume have the patient received? How much was the urine output? How much positive balance? Okay, look for other signs of CCTVR, of perfusion, CCTVR and all those parameters that we talked about. And go back to general medicine. Effusion, how much is the JVP? What is the liver size? Okay, treat the context, not the number, not the sign, not treat the patient. Yeah. So with this particular patient, I asked the father, hey, does your daughter look like this? No. I said, what's different? I couldn't understand, but I know what she means. The face is swollen. Yeah, I said, what about the abdomen? Does she always have this type of abdomen? No, 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 it's like this. So you see, even the father knows. Yeah? So the father knows that this is fluid overload. The fluid that is causing the child to look like this. So the more fluid you give, the more pain, and then the doctor will think, oh, very severe warning sign, more fluid, more pain, until the patient collapses. In those village hospitals in a lot of Asia, there is no ventilator. They don't even have oxygen, right? So you have to stop your fluid. So I stopped the fluid, and all the doctors, they are like, why, they are like, what do you mean? As if like, what is our job if we stop our fluid? Your job is to stop that fluid. All right, so in summary, IV fluid should be managed like the way we manage our drugs. All drugs have got side effects. Fluids pun are the side effects. So there's no ideal IV fluid at this moment. All right, we just have to combine them. So that's why it's an art. Okay, like a cook, you give you the ingredients, but you want to get a good dish. Okay, you got to still practicing to avoid the complications. It's a dynamic situation, so frequent assessment, and you are assessing what the patient's response, or is he not responding? Not according to some perceived protocol. They always tell me, I follow the protocol, I follow the protocol. You shouldn't be following the protocol. You should be following the patient. Doctors who do not know how to follow patients is because they don't know how to examine patients. Okay? So if we don't give adequate fluid, then you make the shock worse. Then they will get bleeding. If you give too much, they will get fluid overload. They will get worse. And to be honest, when they are here and here, there's not much difference. Okay, so you really need to keep to the middle path. All right, when they are just enough. All right. So you may have the knowledge to reduce dengue deaths. Its management is medicine. It's internal medicine. Okay? And we should know our limitations. And if you're a junior doctor, you need to ask for help early. You call your specialist. Don't call another MO. I see my house officers calling another house officer. I said, what is your house officer going to do? Two of them talking to each other, consulting each other. You should be calling the medical officer, and the medical officer should not be consulting another medical officer. They should move the consultation up. All right, so seek help early. And the practice is basic medicine. It is nothing rocket science. People are thinking that, this is high-tech medicine. No, it is not high-tech medicine. It is what our lecturers have taught us in the 5 years as a medical student. All of that, if we put that into practice, it will save a lot of patients' lives. Do we have time? No time. No time, huh? If we have time, I run through a scenario, but maybe we'll do that later. Okay, thank you. So I think that's about it. Yeah.